Hello, MedTech Insight enthusiasts. This is Dr. Jennifer Joe with my co-host, the fabulous Dr. Ami Bhatt. When Dr. Bhatt isn't hosting the show, she's running the Massachusetts General Hospital telecardiology program, which is where she's streaming from live today, seeing congenital heart disease patients and teaching at the Harvard Medical School, where she is a professor. When I'm not hosting the show, I see patients in the emergency room, urgent care, and hospital setting. We both support a number of traditional medtech and up-and-coming digital health startups. We both believe that healthcare can be better, both for the clinician and for the patients. You can find both of us giving local, national, and international talks. And in fact, I'm going to be emceeing the upcoming American Telemedicine Association conference that is going to, I think it's already started. And I am emceeing one of these days that I'm going to prepare for. In a few weeks. So look for me there. And then Ami is also going to talk about where you can find her because she is everywhere as well. And then we also have a Springer textbook coming out, the first ever digital health textbook in cardiovascular medicine for digital health and telemedicine. Again, we are a live weekly interactive talk show. We interview 2 guest leaders in digital health every Tuesday at 12 noon. We also record it, so you can watch us live on either and many different places. So my Facebook page, Ami's Facebook page, MedTech Insights Facebook page, my LinkedIn, and also the Vanguard.Health YouTube page. We love your comments. We love your interactions. We love to hear from you. I think you know that by now. If you are tuning in live in any of these places, YouTube, Facebook, or LinkedIn, if you write your comments, we'll incorporate them into the show. Please let us know who you are, what you're working on, where you're watching from, and any questions that you have for our guest. If you're looking for the current show or the past shows, you can go to Vanguard.Health/MedTech. Vanguard.Health/MedTech Insights, and be sure to follow us by joining our mailing list and look for us on LinkedIn, Facebook, Twitter, and YouTube. Over to you, Ami.
Great. Hi, everybody. Excited to have you with us today. We have had a lot of changes happening in the telemedicine industry over the past 24 hours. One of our excitements is that our guest who will be coming in 2 weeks, we're going to have Ruchika Fernandopol, a good friend, join us, as well as Michael Greeley from Flare Capital. And Ruchika's company, Iora Health, which he co-founded 10 years ago, was just, the agreement was just announced that they are being acquired by One Medical. So what an exciting time to really think about how over the past decade, we've taken the idea of how we deliver care and really incorporated telemedicine, primary care, and thought about bringing that into the community. And so I think that's going to be a great discussion. That'll be 2 weeks from now on June 22nd. But as we lead into that, we always think, what is next, right? Where are we headed next? And that's where our entrepreneurs come from today. So we have Sandeep Pulim and we have Saul Kaplan joining us today. And these are 2 people who have always been thinking about where do we head next. And they've always kept the human-centered design concept at the center of what they do. And what they've really brought to us now is the concept that we don't just want to be in the community closer to patients. We want to grow from patients. We want to be those people who say, what does a patient need, and grow outwards rather than what does a doctor or nurse want to do, and grow inward towards the patient. And so I think today's discussion is really going to be one that even looks a little bit further into how are we going to use telemedicine and digital health to get there. As a reminder, both Jen and I affiliate with and work with many different companies, institutions, but both for us as well as for the representatives here today, we represent ourselves and our own original ideas, not those of the companies that we work for or with, although we're very proud of them. American Telemedicine Association, really exciting month for them. Great lineup. Jen is going to be emceeing. They've asked me to MC, but I'd like our audience to know they asked me to MC on top of our show, and I said, no, I cannot not be present for the show. So I've deferred emceeing this year, but it is a great honor to have been asked, and we'll try and find some times that don't overlap with MedTech Insights next time.
We have to tell them that we have to MC together.
That would be great as well. So exciting there. And then the American Medical Association is also doing really a special series between June 1st and 11th, thinking about telemedicine. And so really excited for their work too. Everybody really thinking about what the future of healthcare needs to look like. And it's not the future, it's really right now. So excited for that. So first today, we're going to start by bringing out Sandeep Pulim. He is a physician entrepreneur and currently the chief medical officer at Bluestream Health, Prior to Bluestream, Dr. Pulim most recently served as Chief and Innovation Officer at Medici. And then prior to joining Medici, he worked to enable cognitive clinical decision-making technology at point of care for healthcare institutions and patients, positively impacting clinical learning and quality measures for healthcare organizations, also working with pharma and payers. Importantly, previously as co-founder and CMO of Health Recovery Solutions, that was where he first started with this concept of really empowering patients to better manage their own health by giving them the evidence and giving them the ability to control the interventions. So why don't we bring on Sandeep Pulim?
Welcome, Sandeep.
Hello. Hey, Jen. Hey, Amy.
So excited to have you with us. This is fantastic. So Sandeep, not everybody out there kind of knows your story. I told them a little bit of it, but what I would love to hear is, you're an MD, you're a practicing clinician, and then you say, I want this to be done better. Will you tell us just a little bit about what drove you in your story to get to Bluestream? And then we'll talk a little bit about what Bluestream actually does so that we can introduce it to people. It's very exciting.
No, absolutely. Thank you again. And as part of that intro, I've been in the startup space now for almost 10 years with Health Recovery Solutions, where we were solving the CHF readmission initial penalties that Medicare put in place about in 2012. So from that, kind of transition to actually moving towards understanding what tools could allow doctors to better understand the challenges that patients are facing. So that kind of led to that cognitive technology that we built at point of care. We're the first ones to actually build a general available GA in terms of IBM language, a Watson tool that was actually functioning. So we're very proud of the work that we did there. And then now at Bluestream, kind of following the evolution of how access to care has changed, what's unique with what we do is as models have evolved from hospital-centric, where it was all based on the value that you could deliver because of some of the financial incentives, shifting to actually more downstream to where patients could access care when and where they need it. And COVID kind of exposed all of this, right? Accelerated all of these challenges and kind of shined a light on how some of these could be overcome. So, we'll talk more into detail, but that's what Bluestream is, a platform that allows you to deliver decentralized care at scale.
That's fantastic. And so you guys at Bluestream, just to give the audience a little bit of background, how many years, and then impress them with how many different organizations and places you have reached already? I think people would love to hear some detail.
Yeah, it's an interesting story. The co-founder, Brian, Yarnell, and Matthew, when Bluestream was started at 5 years ago, it was built actually to solve a unique problem, which was how do you deliver on-demand interpreting services, right? Video interpreting for sign language as well as other languages. And there were other solutions that were out there, but if you're trying to run and manage that business, it was outdated technology. It wasn't built on modern scalable platforms. So since none existed, that's how Bluestream started. And as we started to power the services that organizations were using to allocate their own internal interpreting resources as well as reach out to external networks, that allowed us to get into about 500 hospitals and health systems. And they quickly realized, if we could do this with interpreting services, why couldn't we do this with our own clinical resources, right? So that's kind of how this evolved. And being a true platform, we were able to show them how they could adapt the same tools and technologies to fit into their clinical workflow. So that's how we kind of started to make the transition. And starting in about 2017, that's really when we started to get more heavier onto the clinical workflow side of things.
Fantastic. So I think one of the things that people often talk about is when you have your company and you have an area that you're really interested in, there's the concept of going after that area and doing it in a variety of ways, or saying, no, we have a really good platform. And we're going to take this platform and then we're going to help you apply this platform to many different places. You can tell a little bit that I'm biased towards the latter lately because I think it's actually enabled many of us to speak the same language and do it a little faster. I think do you maybe have some slides or just some information you want to share with us about how Bluestream works so people can understand what that platform looks like?
Yeah, if you can, Jen, share what we mean by a platform, right? So, if you think about today or in your past, 6 to 8 months or almost a year now, when folks had to switch to this remote virtual setting for delivering access to care, people kind of just, organizations that weren't thinking or planning along this line had to quickly adopt tools that they could grab, right? So essentially put something in place to be able to make that access available. But what they found were these traditional video conferencing solutions allow just that encounter, like that ability to connect a patient doctor. But as you start digging deeper, what's really needed is and this is what happened, right? MedStar Health is a great example. They had existing tools that allowed them to do that video encounter. But what they didn't have is the ability to scale this up to the level that they needed. So we were doing work behind the scenes at MedStar using some of this infrastructure, primarily as an enterprise level platform. And they quickly needed a way to scale up their consumer facing side. So because of these APIs that you're seeing on the screen here, you have the tools that you can essentially have like a Lego blocks, right? You can take the pieces that you need and plug in the holes that need to fill in the gaps within your workflow, either EMR based or direct to consumer based. So that was the gap that really allowed them to go from 7 to 10 video visits a day to over 5,000 visits a day, where they were now able to essentially build digital front doors for both patient access as well as provider access, right? So most systems do patient to provider interactions, whereas using these APIs that you see here, you can actually drive provider to provider interactions. And the key that they've found is that if you're able to mirror existing workflows, it increased their adoption. What I mean by that is you can have an intake process, right? You have an entity that already knows what to do when a patient is checking in for their scheduled visit. And as a provider, I'm expected to have certain things in place in the EMR. So when I take over for my part of the visit, I can check that the meds were updated, that everything was already done in terms of screening questions. So I can quickly evaluate that and then focus my attention on what I do as part of my part of the visit. And you can do that all seamlessly. So if you could look, one of the APIs that we have is this integration with interpreting, right? That was one of the key areas that a lot of video solutions didn't have. Is before COVID, a lot of this interpretation was in person, right? So if somebody was sitting across from you, you can bring an interpreter in or have a remote screen that you can bring someone, as a floating head, if you will, on a remote screen. But when you switch to video calls, all of those capabilities were not scalable. So because of our history of starting from interpretation services, it was always native in our DNA to make sure that you are not disenfranchising access to care because someone couldn't speak your language remotely. And so that was one of the key areas. So the work that we did helped FQHCs and New York City Health and Hospitals actually use these APIs to build an on-demand portal for patients in New York City with support for 200 languages and sign language, so that patients who couldn't go to the emergency room during COVID could go to expresscare.nyc, and it looks and feels like it's a New York City Health and Hospital service, which is what we want, right? We're entirely white labeled, so we're behind the scenes, but it was helping them drive, I think, 8,000 consults within the first couple of months that they created this. And that was the other thing. It's a speed to market. So within, I think, 8 weeks, they had a functioning prototype using these APIs. So this, not only is it the video capability, but the ability to deliver and provision access, right? So that's the dirty little secret with virtual care is, how do I make my resources more efficient, right? So rather than going through that schedule first model, because of our APIs and the way we have our patents on this provisioning engine, you can essentially not only capture that request, but deliver the right entity that can help provide the clinical service for that request. So it could either be a patient request or a provider request. And our routing and provisioning engine, within 30 seconds, will find the appropriate entity within your organization that has the current availability and bandwidth. And so there's some rules behind the scenes there. But so that's what differentiates this as a platform versus other video tools out there, is that you're not just focusing on the video, but all the key workflows that people are quickly discovering that are key to operating a virtual first model.
So that's so cool. And Ami, I don't know if you knew this. I trained at MedStar.
I remember that.
At Georgetown. We probably needed something
actually,
like this.
Georgetown. So Georgetown Gen was the first place they tried this, where they built an on-demand referral program for primary care doctors to talk to one of their transplant surgeons at Georgetown.
That's great.
Yep. Yeah, we had a big transplant, and liver transplant was our big thing. That's so cool. Go ahead, Ami. And also, okay, we really
Are there
do appreciate
comments from the audience?
we
Yeah.
really do appreciate everyone watching. We do have Henry Bernstein, who is watching from New Jersey, and he's a 3D technology specialist at Merck. I did not know Merck was working on 3D technology.
Oh, Henry, we're interested, Henry. This is exciting. That's great. So, you touched upon so much, Sandeep. So before COVID, this is one of those things that I and others like me used to go around, and actually maybe it's just me, go around and talk about provider adoption. How are we going to get providers to take on telemedicine, right? And then COVID was like, I'll show you, let me just shut down all in-person communication. And so now provider adoption became less of an issue. And yet it's rearing its head again because one of these, back to normal. What is your new normal? We use the word normal as if it is better or a gold standard. And I think that's where the work that you're doing in ensuring that workflows are not only familiar to the people who are using them, but actually more efficient than what they were doing before. And when you talk about scheduling, that's one of those things. How used to, the concept of having a schedule are we? And you plug into that rather than what do you need? What do they need? Where could this happen? Where could this happen, right? Could it happen virtually? Which type of virtual platform could it happen in person? And really building the schedule as we go in order to allow the best form of care. And that concept is really kind of contrary to the way things are done, but a little bit of what we're talking about of the future of health, which is driving it from both the patient and the provider side, right? Driving their needs for delivering good patient care and then creating the scheduling, the workflow, the interaction that needs to happen. Genie is out there. They're one of the interpreter service firms, very sweet people. I've met with them and we've done demos together. And they found a niche when COVID happened, but I'm sure they're watching you and kicking themselves going, oh, wait, we're a platform too.
Well, we actually want those other partners to use these APIs. Like we're not saying we're the only, it's like you are enabling solutions to be built, right? So we power behavioral health use cases, ED diversion use cases, teletriage. So we're not competing with these partners. We're just making this available. And for organizations that don't have the technical capability to use these APIs, we use them ourselves to give them an off-the-shelf, customized, quick-to-launch solution. So we do that. What our goal is to make these APIs available so other people can build on top of this.
That's great. I love this concept. So I hope everybody out there who's listening heard, right? So willing to collaborate and help you kind of grow your brand, because I think that's really important.
So
go ahead.
Say two things. I think the fitting into the workflow, the fitting into the provider workflow. If you're a new startup, that's huge. Just because working with doctors or clinicians or anyone in the healthcare system, it's hard to learn a new flow, but also fitting into the patient flow, like meeting them where they are, giving them the information and how they want to use it and access it. And then, Ami, I think you were going to mention this, but bringing healthcare to the masses, meaning no matter what language you speak, it's very complicated. We started off with the two-hand phones. I don't know if anyone's ever seen this. Ami and Sandeep, you guys probably remember that. Like, it's hard to get an interpreter for all of the languages. So what you used to have is this. It used to be blue, and it used to be a two-handed phone, and you put the patient on one phone, and then you would take the one phone. But it's hard to actually do that. But the fact, Sandeep, that you are bringing this interpretation in real time and probably in a much more accessible way, I think is huge.
It's within the call itself. So as we're talking right now, you'd essentially be able to click a button and have that party join in. So that's how integrated it is.
That's perfect.
I think that speaks to your point of how telemedicine can actually improve healthcare and close the gap in disparities for America.
So I think that's it, right? And it's not just that you're connecting with your language. When you have a relatively medically knowledgeable, right? It doesn't have to be a clinician, although many times interpreters are, but medically knowledgeable person then doing the translation, you actually are increasing the digital and health literacy of the patients simply by providing that surface. So it's not that you're just doing it in their language. You're actually giving them a leg up on the whole situation by having that. It's almost like having a navigator there with you. And so it's just such a great opportunity. I do want to bring on Saul because I'm certain that he is backstage and like so excited by this conversation. So Saul Kaplan, founder and chief catalyst of the Business Innovation Factory. and author of the Business Model Innovation Factory, How to Stay Relevant When the World is Changing. So note to self, this concept of staying relevant when the world is changing, Saul Kaplan has been doing this for decades. All of us who follow him at BIF are, followers to the nth degree, because you'll just love his thought process about how to really do human-centered design. And we're so excited that he has narrowed down onto health, because he has touched so many other disciplines, and I'm sure he still does. But when he said, I think I want to look more at health, we could have thrown a party. I think we might have. So BIF makes transformational change safer and easier to manage for institutional leaders by helping them explore, test, and commercialize their next practices and new business models. And Saul and the team at BIF are currently designing a new personalized well-being venture called Luna U to address the U.S. maternal health crisis, which is one of those crises near and dear to my heart. So no pun intended. So let's bring on Saul Kaplan.
Welcome, Saul.
What a great conversation. I was enjoying myself in the waiting room. I'm so excited about the idea of extending medical and care paths out to patients where they are. And I thought that was wonderful. Ami, I go further than that. I ask a related but different question. What if we actually created a new model with the patient at the core, not the enterprise, not the physician, the actual patient? And how does the same technologies that we're talking about, to make the medical system more productive, what does it look like if you could actually empower the patient themselves? And Luna U in the maternal health is just an example, but an incredible, powerful example of how, if you could unleash personal agency at the patient level, if you could create a trusted data model that was architected for the patient, not for the institution, all of a sudden you could start to drive personalized well-being, which in a many care paths, as could actually change the outcomes, both clinical and economic. But we didn't design the healthcare system to do that. So we're going to need a new model, and the maternal health example is a really great example, and I'm happy to dig a little deeper with you on this conversation.
Saul, this is great. So we have somebody coming in, Smitha Pillai.
Smitha Pillai, thank you for watching. She's a geriatrician at Mount Sinai Health System in New York City.
Wonderful. So Saul, will you do us a favor, because digging into the maternal health sounds great. Will you give people a little bit of a backdrop as to how you ended up here? Because not everybody knows your story, and it is a great one.
Yep. Yeah, well, I appreciate that. I mean, the short version of it is, first of all, I did grow up and have always been in healthcare. I'm a pharmacist by technical training. My master's work is in the strategic management of technology. So I've always been a geek, and I'm old, so I've been watching this movie for a long time. I went into industry. I worked in the pharma industry directly for Eli Lilly and Company. My big claim to fame, which I'm still proud of to this day, we built the program that brought Prozac, fluoxetine, into the U.S. marketplace, and it was an incredibly sexy technology, with a lot of very nasty tricyclics that were around. So it was a real market-making activity, which really informed a lot of how I think about building new markets that don't really exist, and for a short while, being able to drive and influence how the model works, which comes back to some of the work we need to do in healthcare today. I then went into a very extended road warrior consulting world. I won't bore you with it all. Started at Arthur D. Little, became a senior partner at Accenture, worked with major companies in pharma, medical products, biotechnology. I even worked in the provider side around the world for a number of years. And after all of that experience, I was always amazed at how the rhetoric of change, leaders that said they were going to transform their models, really ended up being more incremental to make the current model and system work. And then fast forward to where we are today, that's no longer sufficient. Last chapter, and then I'll turn it back over to you. After I made a weak effort at retiring, I literally went into government and became an accidental bureaucrat. I ran the Economic Development Agency in my home state of Rhode Island. And it was where I really got the human-centered design bug and started to learn the tool set that would enable us to imagine entire new models designed around the end user, the customer. I almost shudder to call a pregnant woman a patient, right? Pregnancy is not a disease, but yet we try to handle it through the system that's oriented much more to disease than it is to personalized well-being. That government gig is where I founded BIF. We've been doing 70 projects across the country, and Luna U is the first project where we decided we were going to hire ourselves. We were going to self-initiate, pick a design challenge, and we're going to take a model all the way into the market at scale, because the maternal health crisis in America is so egregious that we need a different model. I think everyone knows we need a different model. The question is, how do you get there?
That's perfect. Thank you for bringing your kind of story forward. There were parts of that I didn't know, actually, so that was great. So for those who aren't aware, maternal health is a major issue in the United States. So if you look at other developed countries, everybody has been decreasing their rates of maternal mortality, and we are the only ones that at the same time have been skyrocketing. And so it's a real problem, and it's a systems issue that we have in the way that we deliver healthcare, and it's complex. The state of California has done perhaps the best job thus far in really addressing maternal mortality by first naming it and measuring it at the state level. And so really the measurement of maternal mortality still to this day exists at the state level rather than nationally in the kind of data that we need to be able to make a change. And so Saul, your relationship with the state of Rhode Island, I think, is also going to really help our ability to take, a pilot, if you will, and start and then move national. So Luna U is what you have called it. We would love to hear why the name. We always love, origin stories.
Yeah.
And then thinking a little bit about what do these women do? How do they initiate their own health care, right? Not disease management, but their own health care. And how do you help them find the agency to do that? Because I'm picturing myself as a working mom with one small kid at home, about to have a second, also, managing many other issues, and then, needing to go into weekly appointments. And I have the benefit of being able to have a car or drive there or take time off from work because I wasn't hourly wage at the time, and speaking the same language as my physicians, but that's not the case for everybody. So we'd love to hear about the name, and then a little bit about how does one give somebody enough agency to start their own healthcare.
Well, the name, it was a group process. It was a team effort. We wanted a novel name, and it has no real specific meaning other than we really loved the vibe that it created and the way we had conversations with women about it. And then we started to build a brand around that. But way more important than the brand or the name, the model itself is designed completely through the lens of the woman. And your statistics, not only are we the worst of all the high income nations around the world, which is crazy, but when you start to look underneath that, as you know, the bad outcomes that all women in America face, right? When you start to get into the Medicaid population, when you start to dive into Black and Latino women, we were absolutely amazed when we started looking at this data. Depending on whether you're looking at mortality rates or really serious life-threatening morbidity, 3 times the rate in Black and Latino women. It starts to rise to a level where this is a problem we have got to solve, for social justice issues, for clinical issues, and for economic issues, because it's really expensive. So we built a model and architected a platform that actually engages the woman herself. She gets a steady flow throughout her pregnancy of her own information, both objective measures. We give her a blood pressure cuff and an activity tracker. It feeds into a dashboard where she can actually see. We track 7 well-being indicators, 3 of which are objective measures. The other 4 are self-reported on a set of survey instruments we designed to measure things like empowerment, how she's feeling about and what confidence she thinks she has at influencing her own outcomes, whether she feels her voice is being heard. You know, a lot of this, you know, is caused by racism and social determinants of health. So we give her a really cool user interface and a dashboard. Then we build circles of support. She gets access to a live well-being coach, which plays to the telemedicine piece you're talking about, directly on the platform. But we also help her curate what we call circles of support, or really tight social networks that can share her pregnancy journey, both the good and the bad, as she goes through it, to start to take the stress out. And then we measure and have her self-report her stress levels so she can self-correct and plan her day, her week. She can even plan for her doctor visit, right? Because that's usually a source of stress. There's a lot of distrust, particularly in the Black and Latina community, for the medical system. And we want her to be aware of it. And we want to empower her to recognize it, to call it out, to strengthen her voice when she's interacting with the medical side of this. We started with 30 women, you know, in a low fidelity prototype. We're just now scaling to 400 together with a local insurer. So we're going to start to have the data model and database to be able to draw causal relationships, you know, between engagement metrics and clinical and economic outcome metrics. And we're so confident with the early results and the response that we're getting that I'm now starting to plan for a national rollout and how that model is going to work at scale. So think really big, learn how to solve a problem in a new and different way that isn't the way the current system works. Put it in the market first at a small scale and allow it to emerge organically, right? Because this particular problem is so bad and the outcomes are so poor that we're confident that we're going to be able to show better outcomes, you know, for the population. I'll stop there.
No, this is fantastic. And Jen, I know there may be some comments out there, but I'll do a little origin story for fun. So we talked with Boston Scientific several weeks ago, and they talked about the cocktail napkin and how you would draw something out on a cocktail napkin. And Saul and I had the opportunity to meet several years ago. We had dinner in Boston. I think my hubby maybe joined us that day too. And he said, you know, I think we're going to dive in and do our own thing. And we talked about hypertension for a little while. And you know, that's one of my favorite topics too. But at the time, my mind was on women and maternal mortality. And I will have to give credit where credit is due. My daughter goes to a school called the Windsor School. It's an all-girls school. And they have a global forum. And at their global forum, I was teaching juniors and seniors in high school about issues related to kind of women throughout the world. And I had picked maternal mortality to discuss with them. And the excitement of these juniors and seniors in high school made something that I was giving, which was, you know, a little bit lecture, a little bit Post-it notes on the wall and thinking out loud. And all of a sudden I took this board of Post-its home and I said, what are we going to do? Because there are these bright students out here who can change the world. And that happened to happen the morning before I had dinner with Saul. And he said, is there an area? And so they were actually fortunate enough to be in one of those initial meetings we had at Mass General with some physicians and nurses, Saul and his team, Tori Drew, and we brought the high school students there too. And it's just, it's one of those origin stories of how different things come together, you know, and make you feel motivated. So
no, you're absolutely right. That's absolutely right. We picked it for a lot of reasons, and every day I thank my lucky stars for that, Ami. It's a beautiful use case, right? It's so timely. It's in the public, right? And everyone will say to me, "Who's going to pay for it?" You know, to which I say, "Wait a minute, right? I picked a use case where we can measure improving engagement and its quantitative effect on outcomes, which has escaped us in the wellness space forever, right? And so I'm I'm really focused on maternal health because at the end of a 12-month period, our model goes 3 months beyond the due date because a lot of really bad stuff can happen, at delivery and beyond. But we can actually measure whether it worked. So our business case.
Pillai says the well-being coach is truly a really innovative approach. Thank you, Ashvin, for always tuning in. Sorry, go ahead.
Yeah, no, absolutely. The thing is, it's a systems problem. It requires a system solution. And all of us, particularly in the healthcare world, live in this world where we want the magic bullet, the point solution, the one thing that's going to change the outcomes. That's not how systems work. It's a constellation of things that come together that change the outcomes. And if you want to change the system, you've got to model a different system that brings together a different constellation of activities to drive to a different value or a different set of outcomes. And then you have to allow it to emerge organically, as opposed to our obsession with starting at scale where it has to work for everyone. That's not how we do systems change. And I love the maternal health example, to drive that point home in a really demonstrable way. It's really inspiring work.
This is one of those moments where you realize you brought the two right people together. So Saul, as you were saying all of that, we could have had Sandeep's API model for Bluestream Health up on the screen, right? As you talked about how you have to have all the different factors in place. You have to not take it from the outside and give it to people, but instead let people organically pick what they need, right, to be able to deliver this kind of care and then do it. And I love that. Like, we should at some point, Jen, tape Saul's commentary over Sandeep's picture and see what that looks like, because I love how it comes together. So we're running a little long on time, but I would love to hear from both of you two things. So one question and then kind of final thoughts. But the question is, both of you are talking a little bit about going to large hospital systems and then going to insurers. And we have this discussion on this show and many other places often, which is, which way is the right way? We know that both are the right way, but I'm pushing you a little. Do you have a preference right now, both in general and for your own model, of whether it is better to do it via the payers or whether it is better to do it via a system of providers? We're not going to hold you to it, but we'd just love your thought.
I think we have a unique perspective on this, Ami, because we have insurers using our platform for delivering services. We have hospitals, we have clinics, we have a whole spectrum of providers. And the biggest change that we've seen is that this blurring of the lines between where care is being paid for and how this is delivered, right? So hospital systems are setting up plans. They're actually taking risk for providing care to their pool of patients, whereas health plans, if you look at, they're becoming more vertically integrated, right? They're not just paying for services, they're actually enabling those services for their networks of primary care providers. So there's actually a large health plan in your area that's actually using Bluestream to power their own networks of providers to connect with their patients. And their use cases are similar, but the value propositions are different, right? As a health plan, I'm actually able to deliver against my MLR, right? So you can actually make sure that you're transitioning patients into the right level of care. Is it emergency services? Is it primary care services? As a health system and a hospital, I now have to start competing with consumer-first companies like Roe and Crossover and all these companies now that are raising, billions of dollars in the last quarter. As a hospital executive CEO, I now have to start thinking more about what you just said. How do we deliver care out in the community and make it so that we offer our services and we stay relevant?
Do you think that there's an opportunity for those kind of organizations like Crossover to be able to build along with you their systems? Do you think that that's a potential mechanism? You can tell that I have one medical eyewear on my brain, right?
No, absolutely.
Is there an opportunity for because I'm trying to think for like-minded people, but ones that are kind of missing a little bit of what each other have?
No, as Saul said, right, you've got to start building the concentric levels of care. So one of the things our API allows is for you to bring in your caregiver, right? If I'm talking to a patient, I should be able to bring in whoever that support structure is. And one of the aspects of that we didn't touch on is social determinants of health, right? How do I take a video call and connect you to the local food pantry who doesn't have a camera set up, right? Mm-hmm. So we can actually have SIP integration built into our API that lets you dial a phone number in a video call and hand that patient off to that support structure.
Okay, that's unique. I haven't seen that before.
That is great. That is great.
That's pretty
Yes.
impressive. You should probably have shown that dashboard or something
That's right.
to like prove that it exists.
That's great, Sandeep. I think that's really looking at the innovation horizons of the superpowers or capabilities that you've created, and I think there's tons of room there to start thinking about that. And what you end up doing is heading more towards who are we optimizing for, right? And when you really do go all the way to we're optimizing first for the patient and then for other stakeholders necessary, to improve the outcomes, you get to a very different answer. My answer to your question, Ami, is easy. We're consumer first, right? So payers are way more important on a relative basis than the providers are, right? In our world, if I want to solve maternal health, right, the medical system is going to be there for the really bad consequences when I need them, right? We're not steering anybody away from that. They should continue to interact with the medical system the way they do today. We're providing a trusted empowerment platform for them, right? And we've got to talk with insurers, right? And other payers could be employers that want to make sure that the women in their workforce, want to have access to it. But we're going to go to payers next, and we're going to link providers through the woman. How do we help the woman better interact with the provider on our platform? I mean, providers aren't in our platform, other than the well-being coach. So that's a pretty easy answer for me. We'll see as we scale, how we do, because all those stakeholders are going to be important, to get to the right system.
Absolutely. So maybe I will ask for final comments. Maybe Saul, you, and then Sandeep. Saul, where do you see us broadly going? Take a step back from Luna, you, and you've come so far with so many different models. When we think about healthcare realistically, where do you see us going, and how soon are we going to get there? Is this 20 years? Is this 5 years? How are we going to get there to human-centered design?
Yeah, well, I think this pandemic, was incredible forcing vehicle, as you said before, right? You've got forced to the workarounds, right, in order to keep pedaling the bicycle of the traditional, centralized medical system. And folks like you have been pushing it out, so that you could go to where the patient was because they could no longer come in. I'm really hopeful that a lot of that is going to stick and be resilient and scale, as opposed to the rubber band effect that pulls us back to, let's just go back, to the way this was. So I think it's going to happen a lot faster. I think there will be, very, very rapid escalation of extending the medical system out. And I hope, and I want to be part of launching models that are the true native models that were literally architected and designed, for the consumer, and then stitch in the right medical care practitioners, to that model. And I hope that happens. We're dependent on it. We need it to happen. So it's a both and. Both of those things have to happen.
That's fantastic. And Jen, are you getting little vibes of buoy health too when you're hearing this, right? Like, I think each week we're delving into new areas that we see people going. Sandeep, a slightly different question for you. When you look at Bluestream and you look at our audience who's out there, right? There's tons of people who are thinking, can we work with them? How can we integrate? How will this work for us or for, the venture capital firms who are also watching, and some of them are commenting here. What's next? What does growth look like? Where are you headed? So a little bit about how people can get to you, and then a little bit about maybe where you're headed, if you can share.
Sure. Yeah, I think, Julie Chu said it best, right? It's all about decentralizing access to care. And I think we're able to power the infrastructure that can do that through our APIs. And if you read that recent article with Jen Schneider and Bob Kocher, where they talked about this click and mortar model emerging after post-COVID, I think that's where things are headed, where you now have to be able to adapt as a virtual first, but also transition patients where they need to have access for the more complex issues. And that's going to help eliminate some of the access to care issues where there's limited resources. And I think it's all about building scalable models that can help tap into if it's a value-based model, as well as this transition period you're in. You have to be able to operate in a fee-for-service until that transition happens. So we're seeing a lot of these organizations start shifting. And the ones that are more kind of progressive have already started thinking about it. Like MedStar is a great example. We've been working with them since 2015. So nothing changed. It just accelerated their plans during COVID. Unfortunately, we were able to help them do that. But these other now entrants are coming in. COVID was the first experience they had, right? So they're just now understanding how to do this. And so they find a use case, and now organizations have 5 or 6 different solutions that they have to contend with. And now they're trying to consolidate. And this is the power of platforms, where you can start with what is your pain point today, but you can start evolving in the future. And so that's what's exciting for us, is that we can help power, some of the uncertainty that's out there. If you start building your solutions on these startup platforms, you saw what TruePill did, right? They started as the backend pharmacy for Ro, and now they have their own APIs that you can launch your pharmacy service. So that's what we want to be able to enable for care delivery.
This is fantastic, because it's one of those discussions that reminds you that although we can accelerate, and those people who come to our show and watch our show are those who want to accelerate things, right? Let's just put it out there. So we're talking to like-minded folks here. However, there is a structure that still exists. And I love the fact that you can even say, until fee-for-service goes away. That phrase was not one 2 years ago. We all assumed it would always be here. And on any given day, I may still feel that way. But when we look at how change happens, I think, Saul, you mentioned this earlier too, oftentimes people are saying, well, I'm going to innovate, meaning I'm going to make an incremental change away from the way we're doing things. And Sandeep, your suggestion is excellent. Instead of doing that, look at somewhere that you want to be in the future. Like, that's where we could be. Partner with those people and say, let me take that first step and bring it here. So there is still a mechanism where you're not throwing out everything and restarting from anew, which scares, the C-suites of lots of large organizations. But instead you're saying, don't change from here. Look out there, decide where you want to be, and then start that incremental change. And I hear that message from both Saul and Sandeep. And I think this is why I love chatting with both of you. And Jen and I are so grateful for you both being on the show, because I think our audience gets a sense of, where we really are headed, and that there's a real intelligent way to get there that will work. And so this is great. Jen, I'll give you last word.
Really appreciate Saul and Sandeep joining us, and the discussion about value-based healthcare. It's huge. Going to the patient where they are, I think, is huge. Like always, we really appreciate our audience for joining us every Tuesday at 12 noon. And I guess that's the end of our show. Yes. So Thank you, everybody, for joining us.
Yeah, I'll be back in 2 weeks for that other show.